Well, I appreciate the opportunity to be here and to talk about something that's near and dear to my heart. As Senator Unger said, I am a physician. My practice is in pediatrics, and I've worked for about the past 20 years at Children's Medicine Center, which is the resident teaching program for our young docs that are going to go into pediatrics. And I'm here today wearing several other hats, and one of them is as project director for Keys for Healthy Kids, which has been a grant that's been going on for about 4 years that addresses policy, systems, and environmental change to combat childhood obesity. But the most important hat I wear today is that one representing my patients, your kids, and your grandkids, because you realize that in pediatrics, they don't have a voice. I won't even say they don't have a powerful voice. They don't have a voice. And as many of you know, when we look at these tough economic times, one of the first things that gets cut is not only children's programs, but also programs that have to do with prevention, which is what pediatrics is all about. We'll have Dr. Stallings close his ears, and I'll tell him that the pediatric practice has always been better at prevention than medicine. Oh, you're shaking your head. That makes me happy. You're not going to throw anything at me. Okay, great. One of the other things to think about with this obesity epidemic, and we're specifically focusing on childhood obesity today, but one of the things to think about with this obesity epidemic is that these kids right now are our workforce in the next 20 to 30 years. And what's that going to look like? And one of the most astounding numbers that I've seen recently that lets us know and snapshot into the future is that by 2030, 60% or 6 out of 10 West Virginians will be obese. What's that going to look like for West Virginia when we have 60% of our population that are obese? What jobs are going to want to come here when they know that the cost of health insurance? When we look at the cost of obesity in those realms, I have some numbers for you because I know you like numbers and you like to talk about money. So I broadened my horizons and added that to my little presentation. So let's talk about this. 1.3 million cases of the top 7 chronic diseases are present in our West Virginia population currently, and I'm sure that's no surprise to you. But what's the cost of that? We're just talking about those 7 chronic diseases. The cost to that cost for us in direct patient costs is $2.3 billion. The indirect cost, and the indirect cost we often don't think about, but let's talk about those workers that are 20 to 30 years old, but are not, or 40 or 50, whatever, and are not healthy to perform at their maximum capacity. We call that not absenteeism, but presenteeism. They're absent because they're ill, they're going to the doctor, they're in the hospital, but they're present at work, but not working to full capacity. And the estimated cost in that area is $8.1 billion. And that is a huge number when you really do the cost analysis on obesity. One of the as project director for Keys for Healthy Kids, one of our goals is to improve the health environment for our kids, where they live, learn, play, and pray. We've long been focused on education. We've educated, and I'm sure that there's not one person in this room or one person that we can go out and talk to on the street that doesn't know that an apple is healthier than a cinnamon bun, that doesn't know that it's going to be healthier to run around the park than to sit in the car and play on their phone, Game Boy, whatever else electronic they have attached at their side that they can't even leave at home for a car ride to the park. Everyone knows that. So if everyone knows it, why isn't it being done? Especially for our kids. Our kids are a reflection of our choices. Adults have demanded convenience, and by golly, we got it. But it's killing our kids. The obese rate in kids have tripled over the last decade. I mean, West Virginia's not doing good in that role model category anyway from the amount of chronic disease and obesity that us older folks have, right? But where do kids learn their behavioral habits? And when do they learn it? I still clean my plate. Why? Because of the starving kids in China. When did I learn that? I learned that early on. That's something, I'm almost the big 5-0, and that's something I still fight with constantly, because that was something that was taught to me at an early age when my little brain and neurons were still myelinating, and I remember it to this day. So that's why we really have to shift this chronic disease and obesity focus into pediatrics, where prevention is priority. Okay? The current environment is not only not healthy, and again, we're focusing on where kids live, learn, play, and pray. For adults, we add work in there. For kids, it's learn, which is school. I want to make sure that we're on the same page as far as the obesity epidemic, because when I talk to a lot of different audiences, and I do try to get around, is I talk about obesity not being an adjective. Obesity is not an adjective, it is a disease. And one of the most important reasons that it is a disease is the increase in the risk of diabetes once your BMI or you become overweight or obese. As I said, the rates in childhood have tripled over the last decade. When I was a young doctor training, as I trained my residents, there was no such thing as type 2 diabetes. It was adult onset diabetes. Why? Because adults got it, kids didn't. The only thing I learned how to take care of was type 1 diabetes. So when I started trying to teach residents how to take care of weight and health effectively in the clinic, one of the first things that I did was essentially had to go back to school to learn the umpteen thousand different hypertension and diabetes and cholesterol medicines. A statin to me, Dr. Neal, was something that didn't move. It wasn't a cholesterol medicine. So by golly, I couldn't teach the other residents when myself, and I was an academic pediatrician, I really prided myself on making sure I was up to date on every little nook and cranny of pediatrics. And this was an area I couldn't keep up with because it was adult medicine creeping into pediatrics. And it has continued to do so. As a matter of fact, if you run the if I had my pretty slideshow, you run the CDC slides across of, those little maps, everybody's seen them, of the rate of obesity. At the top of the screen, along the bottom, you run the same thing with diabetes, and they're gonna mimic each other. So from now on, when you talk to folks, I would like to recommend that you use the word diabesity, because that makes sure we're talking about the same thing, that it's a disease, it's not an adjective, and there are consequences, not only to our children, but to ourselves, or actually us reflecting on our kids. And I often think, why haven't we moved the needle? Now, the adult needle I'm not going to talk about, because there are very few things I totally give hope up on, and that may be one of them. But you know what? We have moved the needle in pediatrics. And Dr. Neal's going to tell you about cardiac, which is one of the most important reasons in the state of West Virginia that we've moved that needle. And we've moved that needle because we have started focusing on early child care, which is important. And we've moved that needle because of our strong policies in our school system, which we already know is effective. And as a matter of fact, West Virginia has been highlighted recently by the CDC, Robert Wood Johnson Foundation, and a new foundation called Voices for Healthy Kids. We were 1 in 7 states that had a plateau or decrease in childhood obesity. And I think that's something to be celebrated. Don't clap or anything. All right, so the people that have made those recommendations are folks that study this, okay? It's the Institute of Medicine. It's the American Academy of Pediatrics. It's the Center Disease for Control and Robert Wood Johnson Foundation, which have donated like $45 million in obesity prevention. They started within the school setting, which is why now we're starting to see some of those pediatric trend numbers come down. And Healthy Kids, Healthy Communities, of which Keys for Healthy Kids was part of their community branch. So we actually have functioned outside of the school bells over the past 4 years to really build capacity on preschool programs, from the school day, as well as preschool programs and after school programs, and how we can achieve the not only health, nutrition, and physical activity goals, but also the academic goals in after school. When we started looking at what to do for kids and physical activity, I will tell you we didn't originally start with what we've ended up with. We've really changed this and morphed this a lot, and that was through the whole process of Our Children, Our Future. And I believe I saw Stephen Smith walk in. He can wave to everyone. So we've worked on this for about the last 6 to 9 months. And when we started, we actually started working on policy and after-school centers. Because again, we were Keys, and we wanted to work outside the school bell. And the more people we talked to, the more focus groups we did, and these were in the community. This was not at the school level. We weren't talking to PE teachers. We weren't talking to principals. We weren't talking to superintendents. We were talking to kids and their families. And one of the things that we heard from them was, well, why are you working in after school? Why don't you just get us our recess back? And I'm like, when did recess go away? Did you all have recess? Everybody that had recess, raise your hand. You didn't have recess? You did? Yeah. And did you have recess every day?
Yes.
Yes. And how about gym class? Did you have gym class every day? Or was it once a week?
2 or 3 times a week.
Yeah, 2 or 3 times a week. So when we started talking to kids and families about this, they are really the ones that kind of nudged us into the during school day activity because of what they perceived as a lack of physical activity. The biggest scream was for recess. And I remember going back and telling the Keys coordinator, Laura Dice, I didn't think in my day I would ever have to fight for recess. That's just not one thing I thought I would have to fight for. So why do you think recess is gone? Test scores. And what pushed test scores?
No child left behind.
Thank you. So No Child Left Behind, which if we know that in a negative connotative way, let's talk to principals, teachers, and folks that try to educate our kids, because they can't educate our kids and see the forest for the trees because of so many regulations that have been shoved down their throats and what have you, which is exactly why when we first started this physical activity or recess proposal, that we did start in after school hours because of the stress on the school system currently. Then we, again, went back to our community, and most of this has come from them. It has come from community workshops and meetings that we've had through our Children, Our Future campaign, and a playoff of Senator Unger's bill, Feed to Achieve, last year. And really looking at Feed to Achieve, and this document here called Educating the Student Body, which is a document from the Institute of Medicine that talks about educating the whole child and about how physical activity is part of educating the whole child, and that physical activity and the lack thereof may be the missing link, and why increasing time in math, science, and reading, and increasing time and further increasing that time just a wee bit more hasn't worked to move the needle on the test scores. Okay? So I'm going to flash forward and tell you what our proposal is. And it's on the one-pager that's in your handout. And it's called Our Children, Our Future, because that was the name of the campaign that we participated in. And the vote is this Friday. So if anybody isn't signed up to vote on the platform for Our Children, Our Future, who wants to vote for the physical activity platform, see me, and I'll give you that email to vote on that platform. And it's Our Kids Need Physical Activity in Recess Too. And to be honest, I came about and into this because it was the demand of the kids and the families that we were talking to. For me, I'm in it for the health and well-being of our children because it's just simply the right thing to do, and I feel like as a pediatrician I have to be the children's voice. For the school, it should be all about academics because what's kind of started this whole thing was No Child Left Behind and the pressures put on in the school setting and kind of the weaving out of that recess and physical activity. And this is the proposal that we came up with and why. I've talked about the childhood obesity background, and we all know that the importance of childhood obesity really is what you take in calories, amount, and quality, and how you burn that off, amount and quality. It's pretty simple. Currently, the Board of Ed policy follows the West Virginia Healthy Lifestyle Act of 2005 and calls for not less than 3 days of PE per week. Number one, when we started working on this policy, no one could give us the information of how often are our kids getting PE. No one could give us information on how often are our kids getting recess. What we did have were the exemptions, and saw the number of exemptions coming from elementary and middle schools that showed the reasons that they checked the box that they didn't even have to have PE 3 times a week. And those exemptions had to do with lack of appropriate space, and that comes from the days when we tried to make the gymnasium the multipurpose room. So it's the gymnasium, the meeting room, the music room, the everything else. So if they couldn't go outside to the playground, there wasn't anywhere within the school that could hold gym. And lack of staffing. I mean, obviously lack of qualified teachers to teach physical education. Also, you probably know that the physical education bill has been brought forth several times, and it usually gets killed because of the fiscal note, because of hiring all those needed teachers and building all those gyms. So we decided to take the low road, and instead of advocating for after school, we changed to PE every day, and then in our final draft, it really was to meet the goal of all the national experts to have kids have 60 minutes of play a day. And to do that, we are requesting 30 minutes of additional physical activity time in each school day. And that can happen before school, during school, with instant recess, active academics. It's happening all over West Virginia, and I'm sure Kate Long can show us some of those successful stories since she has PowerPoint presentation back there. It's happening, and schools are successfully doing it. So we know it can be done. Why would schools be interested in doing it? From the schools, especially the whole regions, like in Mingo County that have been doing it, they're also getting some secondary gain. Not only have their dropout rates gone down, school absences have gone down. The last time I talked to Randy Keithley about 2 months ago, he had not suspended a kid in 18 months. Now remember, I'm talking about Mingo County. The disciplines, the attention, and the presentation of schools all increased when they instituted, they get 60 minutes a day. They get 30 minutes of PA physical activity and 30 minutes of physical education every single day in every elementary school in Mingo County. So not only did they see what science has told us about the grades and the test scores increasing, they also see on test scores increase abstract thinking and problem solving, which is definitely what we want our kids of the future to be able to do. The other aspects of our proposal is not only the additional of the 30 minutes of physical activity, but again, making sure that's quality time, which means the kids are moving around and sweating. We call that moderate to vigorous physical activity. To be honest, everybody gets caught up on what does that mean. Can you tell if a kid is sitting down and not active versus running around with a red face and sweating? That's all we're talking about. It's very simple. Are the kids up and moving? And as adults, are we making that fun for them? The last part of this really came from the Office of Healthy Schools, which has since been dissolved. And that is the accountability, that if there's no accountability for this, it's going to not happen, and we're going to run into the same problem that we did with the Healthy Lifestyle Act of 2005. And we're actually meeting with a group of principals on Thursday, thanks to Chuck Heinlein, that has arranged this for us to talk to the principals, because that was one group of folks that we were missing, to find out what's the best way for that accountability, because we don't want to add load, stress, and nonsense to our school system and or our teachers. And then the last is training, because we feel like the teachers need to see other classrooms that have successfully instituted the 30 minutes, and not only see how it's done, but to see that kids can get up and have a 10-minute instant recess and just let everything out and come back and sit down and learn and pay attention. One of the biggest things we heard from the teachers is that if I get up and do a 10-minute recess, it's going to take me another 10 minutes to get the kids calmed down, and it actually turns out to be completely the opposite. And if I had time to go into neuroscience with you, I'd let you know why that was, but I don't think I have time.